to this Meet the Expert session sponsored by ASAHI Medical. We have the pleasure to have Professor Domenico Santoro with us, and he is going to debate with us about the nature of new membranes and the possibility offered by new membranes. As you know, we have now quite a large spectrum of membranes that make possible removal of molecules in a wide spectrum of molecular weights. We have recently published in CJSON a new revision of the classification of molecules of uremic solutes, including the so-called middle molecules in a spectrum that is defined by small, middle, and large middle molecules, moving from 5,000 to 58,000 daltons. So at this point, we need membranes with different clearance capabilities. And we also published recently in Nature a review article on dialysis membranes, when we described two of the important parameters to be considered in a membrane. One is the cutoff, where the sieving coefficient approximates 0.1. The other is the retention onset, where the sieving coefficient approximates 0.9. The most recent so-called medium cutoff membranes that are also defined by high retention characteristics seem to have shifted the sieving curve to the right, somehow resembling the level of sieving that we have in the human glomerulus. At this point, I would like to ask Professor Santoro, in general, what do you think about the molecules that are retained in the uremic syndrome and are not filtered by the conventional membrane?
Oh, thank you very much, Professor Ronco. Yes, this is a very important point, because recent study demonstrated how the purification of toxic molecules above 15 kilodalton is not optimal. And there are in the literature a large number of middle-sized molecules that have been associated with the symptoms, with the clinical condition of the uremic patient, especially with inflammation and dysfunction of the immune system. As an expansion, we can mention some of these molecules, for example, complement factor D, various cytokines such as interleukin-6, interleukin-1 beta, kappa lambda light change. All these molecules are related with mortality in the uremia. As you said, some of the molecules are not removed by the standard hemodialysis, in particular with low flux membranes, and even little with very high flux membrane. And you demonstrated in the last two papers that you showed that there are new techniques that can remove these molecules, especially, for example, with a typical example of high retention onset molecules.
Membranes.
Membranes.
Yes, but for example, do you think there is a correlation between retention molecules in the middle to high molecular weight range and the specific outcomes?
Yes, I think so, because these molecules are related with some of the mechanism that it may induce inflammation and may induce increase in the radical products, and this both the situation, increasing radicals and so increasing the inflammation, can cause some of the main clinical syndrome that we see in patients with uremia. And for example, we see some of these typical symptoms can be enhanced by this situation. For example, anemia, for example, cardiovascular complication.
And what do you think about these molecules in case of acute kidney injury, when the patient presents sudden oliguric state and acute retention of toxin. We have the same type of molecules, the same mechanism. Are they enhanced? What do you think?
Well, I think that we cannot compare acute and chronic situation in patient on in patient that need to be dialyzed. But anyway, there are some molecules, there are some situations such as inflammation, for example, that can be considered different in terms of dynamic process. As an example, we know that inflammation is a situation that can occur in chronic patient that can also enhance, for example, comorbidity. We know that patients on hemodialysis are more prone to have a reduction response, for example, to the vaccines. And this is related also to dysfunction of immune system and related also to a chronic inflammation at a lower level. In acute patient, we have inflammation at higher level, and this can be also treated in the same way, but with different techniques that we can use in extracorporeal treatment.
I think one of the example of this patient is the COVID-19 patient that has a very often an impending cytokine storm and cytokine release syndrome. And indeed, in a recent consensus statement published in Nature Review Nephrology, the so-called high retention onset membranes are recommended as a potential treatment to remove cytokines. Now, how much do you think a different membrane can influence the outcome of a dialysis treatment? In other words, do you think that by changing or shifting to this new high retention onset membranes, we can modify the outcome of patients, or at least we can modify some specific outcomes?
Yes, dialysis membranes are the key elements of extracorporeal treatment, and the choice of these membranes in the wide range of products that now are available should be functional to the therapeutic goal that we plan to the patient and to the patient clinical needs. So the selection should be consider the type of membrane, the surface, sterilization, permeability, and also the coefficient of ultrafiltration, and also the so-called cutoff for the size of the molecules. We know that when people think to the membrane, the studies has been focused on increased permeability and selectivity, together with also modifying of a membrane hemoreactivity. And this has been made to expand the spectrum of uremic toxin that can be removed. And this can be due just to the modification of the chemical compounds of the membranes.
Now, it's interesting that you mentioned this, because when you mention cutoff, we are confronting these membranes with, for example, high cutoff membranes. And the main difference is that these membranes are supposed to retain albumin or have negligible albumin losses. So do you think that these negligible albumin losses are important, or in our experience, we have been treating patients now for more than 2 years with high retention onset membranes, and there was no difference in albumin. Actually, we observed a kind of paradox effect. We lose a little bit of albumin in the treatment, but the albumin in the patient increase because the appetite increase and nutrition increase. Do you have the same experience?
Yes, I agree exactly with you, because when you improve the clinical situation, the clinical well-being of the patient, you have two results. One is that you increase the appetite of the patient, so the patient can increase their albumin through increase the production of albumin. And another reason, another situation is that when you treat the patient, you reduce the inflammation. And we know that albumin is a negative protein of the inflammation. So if you reduce inflammation, you have an increase of a negative protein of inflammation, and one is albumin.
That is true because, as you mentioned, albumin is a negative acute phase reactant or protein. And in fact, one of the other aspects that we see normally when we treat with this membrane in chronic patient is not only a better appetite and nutrition, but also a better strength and quality of life, assuming that some of the molecules are somehow correlated to this weakness, sometimes some muscular weakness and so on. In the acute patient, the benefit we consider, and it is the rationale for application, is the removal of acute phase reactants and cytokines and mediators, somehow to protect the endothelium, and especially to protect patients in the acute phase of sepsis when they have a completely disrupted immune system. Do you have the same view, or do you share the same view, or do you think there are other issues that can be discussed?
No, I think that this is a very important point, because when you use this type of a membrane, we reduce in the blood of this patient some of the factors, some of the cytokines that can you mentioned it, for example, the COVID-19 patient, you know, and where is the storm, cytokine storm. And when we treat patient with this kind of situation, one of the factors that can be related to the improved clinical syndrome of this patient is just the removal of these cytokines. So I agree perfectly with you.
Well, in fact, I think this is one of the interesting issues. The other issue that is interesting to me is the indication in the chronic patient. Somehow a question may arise: should we treat patients who develop complications, or should we treat patients that are incident, that just started dialysis, in order to avoid long-term complications? Assuming, theoretically speaking, if this becomes the new golden standard, probably we should treat every patient. But what patient, in your vision, as a priority?
Well, when we have an improvement in the technical system in medicine, I think that we should apply, if the, of course, sometimes there is a problem of economical problems that can be a barrier to apply to all the patient the same improvement in the technical system. Anyway, I would not treat patient when they are already complicated, because sometimes the patient, when you treat in this at this time, it is the point of no return. So you cannot get better that patient, because the situation is already complicated. I think that we should start to treat this patient at the incident, when they start hemodialysis. And of course, the age of patient in dialysis is, we know that is always increased in terms of incidence of patients. So we should start to, we have very few patients that start dialysis at class of age like 40, 50. There is a very small percentage. We have a lot of percentage of patients that start dialysis after 55, 70 years old. And why we should not treat this patient with this type of membrane? Because now the age of dialysis can be very increased with type of membranes. I think so. This is my opinion.
Well, moving to, again, back to the acute patient, but the consideration can be good for the chronic patient as well, because we have matured some experience now over the years. You know that membrane can be functionalized. And in particular, ASAHI has developed a proprietary technique to covalently bind vitamin E, alpha tocopherol, to the surface of the membrane on the, let's say, blood membrane interface. This addition that is called surface modification or functionalization of the membrane is made with the rationale that, one, you can remove reactive oxygen species from the circulation exactly in the point where they are generated because of the blood membrane contact and the stress. And also you can remove the exceeding amount of free radicals and reactive oxygen species that are generated due, for example, to the acute kidney injury process and so on. So what is, in your view, the advantage of high retention onset with the surface modification and this special addition?
Perfect. Just let me to make a like to start by the fact that some of the major role in the pathophysiology of the major comorbidities, such as cardiovascular damage, dysregulation of immunity, inflammation, we already said malnutrition and anemic state, is played by the ROS, reactive oxygen species, and by the oxygen radicals that are present, as you said, in the circulation of the uremic patient. And these molecules are produced just with the contact of the blood with the membranes. And so having something that can react with the substance is it has been a very important innovation in this membrane. These radicals are molecules that can oxidate other molecules, altering the biological function. We know, for example, the proteins that can be damaged, the LDL, and also erythrocyte can be altered, and so we can have an excess of loss of erythrocyte. So the ability of a membrane to modulate this process is a very important factor. We know that membrane binding antioxidant substances such as alpha tocopherol are able to modulate the oxidative damage because they interact with these molecules and fighting this action of free radicals, thus improving at the same time the eco-compatibility of the system.
We have tested these membranes at the beginning. We have Exabrain, and then we use Vitabrain and so on. And in the chronic patients, these membranes have shown in studies to reduce the requirement of erythropoietin, probably because, as you mentioned, they create a better environment for red cells, which are victims of this reactive oxygen species. And in the long term, possibly, there is less oxidation of lipoproteins that represent an important risk factor for cardiovascular disease. In the acute patient, we have documented in a study the significantly reduced amount of production of oxygen species, or we don't know, we just noticed the reduction in the serum concentration compared to a patient treated with another membrane, showing that it is probably true that when reactive oxygen species are generated, we can remove it exactly at the site of production in one sense, which is the membrane, but we can also remove these molecules that are already circulating because of general production in the organism. Now, one of the important aspects that, in my view, is the combination of a surface modified membrane like this with an high retention onset molecule is that you combine absorption, removal, and scavenging of these ROS. However, as you know, middle to large molecules require some convection to be removed. And we have the experience now with expanded hemodialysis, for example, that this convection is achieved by internal filtration. Can you comment on this aspect?
Yes. Firstly, let me add to the one thing that you said before regarding the improvement of anemia is related also. I saw some very interesting paper. There is also a reduction in the ASA erythropoietin stimulating agent use because this patient have an anemia less resistant to erythropoietin. This is another important aspect that can be related also to reduce the inflammation that we know that is a factor that make resistant to erythropoietin therapy. Anyway, you said the point that you say now, it's another important aspect, and I think that we can have this opportunity for our patients, and that can improve the clinical situation of our patients.
So the summary of what we discussed so far is basically we have now clear evidence that molecules in the middle to high molecular weight range correlate with bad outcomes and are responsible of some of the signs and symptoms in the chronic uremic patient, but also in the acute kidney injury patient. These molecules represent an important target for removal, and that's why porosity of the membrane, which is somehow expanded because the average pore size is greater in medium cutoff or high retention onset membrane, provides better removal of these substances. On the other hand, we know that these substances have a limited diffusion coefficient and require some convection to be removed. And in filters equipped with MCO membranes, basically internal filtration plays the important role that in other conditions is played by hemodiafiltration, for example. These membranes probably are not optimally used in hemodiafiltration because we might experience excessive albumin loss, and safety may be a concern. But in internal filtration mechanism, we have demonstrated that there are no changes in albumin. The opposite is true, that albumin tends to improve because of the removal of large quantities of pro-inflammatory substances and reduction in inflammation. Finally, these membranes equipped with the new technology, which is a surface modification and functionalization, may add an important aspect that you correctly define bioproperty, which is the possibility to block reactive oxygen species at the point of generation or remove reactive oxygen species that are circulating and that may indeed aggravate the inflammatory situation and may modify other molecules, oxidizing proteins, etc., etc. So if you had to summarize in one sentence or two, what do you expect from the future from these membranes, both in the chronic and the acute patient? How would you see the future in this case?
Well, we know that hemodialysis is one of the great advances in the last century regarding the treatment that we can have for in general for the patient, but especially for a patient with kidney disease. And even at the start, the hemodialysis was just to save the life of the patient. In the course of the years, hemodialysis, the goal of hemodialysis was to improve the quality of life. And the quality of life is the best when you have your kidney. So the technology is improving to make the filters just like a glomerulus. As you said, the removal of the substances are mimicking always more the filtration process that we have inside the glomerulus. So I think that we are not very close to the glomerulus, but so the artificial kidney completely that you always said. But I think that our patient can be satisfied at this point for the improvement in technologies that we have in nephrology. And you are one of the leaders that make this possible.
So thank you very much, and thanks to ASAHI Medical for sponsoring this symposium. We now need to go back to the scientific program of the 39, the Vicenza course on AKI and CRRT. We thank Professor Santoro for his presence and his presentation, and let's see what the future will present us in terms of further development of this technology. Thank you so much.
Thank you too, Professor Ronco, for your invitation. Bye.